Hello and welcome everyone. And today we are going to do one of the short topics, but one of the very important topics that comes in every theory exam. And also it is very important from practical point of view, because many of our vivas, when it's on regional anesthesia, when it's on spinal, epidural, it may lead to this point where you have to talk about post-dural puncture headache. Okay. So it's a nice topic, and a lot of you all must not be knowing about the pathophysiology, what is the exact treatment, how do you manage, how do you prevent PDPH. But I'm sure that a lot of you actually have noticed that your patients have PDPH. So today, let's look into this topic in detail. First of all, when you're asked in the exam, what is the definition of PDPH? Okay, so most of you will say random things like, yes, there is a hole that is created in the dura while giving spinal or epidural anesthesia, and that may end up causing a CSF leak. Okay, so whenever you're talking in the exam, you have to give the exact specifics. So what do you mean by exact specifics? The first thing is you have to say that it is a complication of which procedure. Okay, so PDPH or post-dural puncture headache is a complication of two commonly done procedures in medicine. I'm not talking specifically about anesthesia, but you have to remember it is in medicine. Okay. So in anesthesia, in spinal and epidural. Okay. And actually, if you see in medicine, many a times we do lumbar puncture, and this lumbar puncture can also lead to PDPH. Okay. Now, these are the causes of the complication. What exactly happens in the complication? So there is a hole that is created in the durameter. All right. And what does this hole in the durameter lead to? This hole in the durameter leads to CSF leak. So what is the problem that happens because of the CSF leaking out of the hole? So there is a fall in the intracranial pressure. Okay. So as we all know, there is something that you need to know, which is very important. I don't know if you all have done this in physiology when you all were doing MBBS, but this is called as the Monro-Kellie doctrine. Okay. So what does the Monro-Kellie doctrine say? The Monro-Kellie doctrine says that in the brain, there are three compartments. Okay. So you have a compartment of parenchyma, and then you have two compartments. One is of blood and one is of CSF. All right. Now, the pressure that all these three compartments give rise to remains more or less constant. So, for example, imagine that someone gets hurt on the head and there is sudden bleeding in the brain. So, this compartment is increasing because the vessels have been avulsed and there is bleeding in the brain, correct? So, if this compartment is increasing in size, automatically the CSF tends to move downwards towards the spinal column. The parenchyma tends to get pushed downwards. Why is all this happening? Because the brain or the cranial cavity is trying to maintain a constant pressure in this cranial cavity compartment. Okay. And it is trying to accommodate for that sudden increase in the size of the blood compartment. So this is called as Monro-Kellie doctrine. All right. Similarly, something that we see many a times, if you have a patient, neuro-onco patient, someone who has a tumor in the brain. Okay. So here imagine that because of the tumor in the brain, your parenchyma is increasing in size. Okay, so again, we have the blood, we have the CSF, and then we have the parenchyma. Okay, now if the parenchyma is increasing in size because you're getting a tumor over here, so what will happen? The blood vessels will start vasoconstricting. Okay, there will be cerebral vasoconstriction. Along with that, what you will also have is that your CSF will start getting pushed down towards the spinal canal. Why? So that the space is made for the rise in change, for the increase in the parenchyma. Okay, so this is called as the Monro-Kellie doctrine. All right. Now, as you are losing CSF from the dural puncture, okay? Now, this CSF leak is leading to a decrease in the intracranial pressure. Obviously, the parenchyma cannot suddenly increase in size, but what can happen is that the blood vessels can dilate. We'll come to that when we study about the pathophysiology of PDPH. Now, I wanted to tell you one very fun episode over here. So, PDPH was first described by August Bier in 1898. All right. Now, a little bit of history lesson for you all. August Bier was actually a surgeon. All right. And he decided to experiment with spinal anesthesia or subarachnoid block. And what he did was, in this year 1898, he gave spinal anesthesia to 6 patients. Okay. And the drug that he used is cocaine. As we all know, cocaine was the first local anesthetic to be used. The first person to use cocaine as local anesthetic in topical eye drops was Carl Kohler. Okay. So he said, okay, he used it for eyes. Now let me try and put this in the subarachnoid space. So he called it as cocainization of the spine. He called it as cocainization of the spine. Okay. Now, after a few days, August Bier decided he saw that, whenever he's giving this cocaine in the spine, in the subarachnoid space, his patients are getting good um, pain relief and they are awake, but they are allowing him to perform the surgery. All right. Then after 6 patients, he decided that let me try this on myself. What exactly does the patient feel? Okay, very daring person. So what he did was he had an assistant called Hilbrand. So he asked Hilbrand, can you give me spinal anesthesia? Hilbrand said, okay, of course, if I'm getting a chance to put a needle in the back of my boss, why not? So what he did was that he put the needle in his back, and when they reached this subarachnoid space, the CSF started dripping out. Now, Hilbrand took a syringe which was not fitting inside the spinal needle. Okay, so just imagine you have removed the stillet and the CSF is dripping out, and Hilbrand is trying to attach the syringe and it's not happening. So a lot of time got wasted in all of this, and as a result of this, they could not give the cocaine inside the subarachnoid space. All right. So after this, August Bier got very angry. He thought that Hilbrand is playing with him. So what he did was, on the same day evening, he said, now I will perform the spinal on you and show you. So what August Bier did was, he now took a syringe which fits properly inside the spinal needle, and he performed the subarachnoid block and gave the cocaine to Hilbrand. And then he asked Hilbrand, how do you feel? So he said, I can't, initially I felt some tingling in my legs. Now I feel numbness and I feel heaviness in my legs, all those things. Now, after a couple of days, both Hilbrand and August Bier started getting severe headache. Okay. And this headache was accompanied with nausea, vomiting, tinnitus. In case of Hilbrand, the headache subsided on its own in 2 days. But in case of August Bier, because they wasted so much time trying to remove the syringe, attach the syringe, try to play with the syringe, a lot of CSF flowed out, and it took him 9 days to recover from the headache. And because it took him 9 days to recover from the headache, August Bier decided to write an article about this, which is the first article about post-dural puncture headache. Okay. So that is the history of PDPH.